Our first speaker today is Professor Craig Anderson, who will be basically joining us from wherever he is in the world, which is London. So this is a pre-recorded talk that Craig put together for us because unfortunately he's over there working at the moment. Unfortunate for us, but certainly not unfortunate for him. So I'll just do the introduction of Craig and then we will basically move into the recorded talk that he has given to us. Professor Craig Anderson, a long-time supporter of the Stroke Recovery Association, a real mentor, in fact, to a lot of people who have had a stroke. Craig is a Professor of Neurology and Epidemiology in the Faculty of Medicine at the University of New South Wales and is a clinical academic neurologist at Royal Prince Alfred Hospital, Sydney, Australia. He is the Executive Director of the George Institute China at the Peking University Health Science Centre in Beijing. Craig holds specialist qualifications in clinical neurology and geriatrics, a PhD in medicine and epidemiology from the University of Western Australia. He is a Senior Principal Research Fellow of the National Health and Medical Research Council of Australia. He is a past president of the Asia Pacific Stroke Organisation and the Stroke Society of Australasia. He is a member of the several specialist societies and an editor of the Cochrane Stroke Group. Group, it's a different thing. He has published widely on the clinical and epidemiological aspects of stroke, cardiovascular disease and aged care. He has led several large-scale investigator-initiated epidemiological and clinical trials that have had a major influence on the clinical practice and guidelines for stroke treatment and prevention. It's an absolute pleasure and privilege to welcome Craig to present his talk to us today. Thank you.
Hello, my name's Professor Craig Anderson, and it's a great pleasure to give a presentation on how research is used to inform best practice in stroke at this year's training conference of New South Wales Stroke Recovery Association. My apologies for not being there in person. I'm sending this video from London, and I'm sure that my colleague Professor Ken Butcher will be well able to answer any questions that may arise following. What I'd like to cover is a brief overview of how stroke services have emerged over the last few decades to the current organisation at a regional level, with a particular emphasis on reperfusion therapy, which is the mainstay of treatment for acute ischemic stroke. I'll touch on some other strategies, but mainly to highlight the importance of randomized controlled trials in how we formulate decisions in which treatments to apply for people who've had a stroke or at risk of stroke, and to prevent further strokes from occurring in the future. Now, I was training as a physician in the 80s, and the management of stroke was very rudimentary. If this is a diagram of beds and cross-sectionally in a ward with patients in each of the wards, there was a tendency for the stroke patients in the blue to be moved to a single side bay because they were sick, very disabled, and are highly likely to die in the next few days. And we had no treatments. So when we did a ward round, we gave a lot of attention to patients in the main bays, but when it came to the patients in the side bays with stroke, given much less attention. And we often termed this ward round the hemiplegic ward round because things weren't working so well in those in the side bays. The brain imaging scans that we had at the time, first generation, were not very good in terms of their resolution and quality, and we did the scan purely for diagnostic reasons a day or two after the person was admitted, because there was no urgency. We did not have any therapies that were dependent on making a rapid diagnosis. So the way in which we organised our teams was not with any degree of expertise, focus, training or interest in stroke, and really all that we had available in terms of treatment was intravenous fluid. So it's remarkable how modern stroke therapy has evolved. We now recognise time is brain and there's an urgency in which to do things. The triaging and rapid transfer of patients in the emergency department to the scanner to receive treatment. And we well recognise now that to give the best care to our patients involved organising different skill sets as part of a expert and trained and interested multidisciplinary team. This idea of time is brain is very important to us. When a blood vessel blocks in the brain, the brain cells die off very quickly, by the minute. And if we can restore oxygen, blood flow in that particular region, we can heal and even resolve any damage that's occurring. So how have we come to this state of affairs in understanding modern treatment for stroke? Well, I feel that for every 5 or 10 years we make a major breakthrough. And it started in the 80s when I was training, and I feel very privileged that I've been able to catch these 5 or 10-year waves of major advances in stroke. In the 80s, we recognised that to measure the pattern and the outcome of people who've had a stroke, we need to do epidemiological studies, whole of population studies in large numbers. And not just patients who've presented to hospital, but patients who've had a stroke with mild symptoms, who never get to hospital, who may die rapidly. And this was able to allow us to get an accurate measure of how stroke occurs and how it affects people in a variety of manners. Subsequent to that, people recognise that it's very important to pull data together to make sense of it and to come up with some conclusions. And a particular organisation was formed called the Cochrane Collaboration, and a particular section of the Cochrane Collaboration was devoted to stroke, and out of that arose a meta-analysis, the pooling of research studies in terms of randomized controlled trials that shows that overall the evidence was positive, that when you organise stroke care in teams, in specialised units, geographically located in a particular section of the hospital, you get a better outcome. The major change occurred in 1995 with the American NINS TPA, or thrombolysis trial, that shows if you could administer the treatment very early, you would get an outcome. This was revolutionary, and it led to the regulation and subsequent licensing approval for use of TPA all around the world. In the early 2000s, there were big trials looking at secondary prevention. I was fortunate to be part of the management team for Progress, but there were other trials looking at cholesterol lowering, use of aspirin. In the last 10 years, we've developed a lot more information around brain imaging, the blood flow. We've been able to measure particular patterns of stroke, and we have a better understanding of the causes, the risk factors for stroke. The most recent big change has been in terms of clot retrieval, the ability to put in a small wire suction or net retriever that can improve outcome. And it started with a Dutch trial, which was called Mr. Clean, and it was published in announced in October 2015 to great excitement, and that's really pushed or revolutionised the way in which we manage acute stroke. We now can map out the blockage or low blood fat flow or the clot in the blood vessel in the brain. We can even map out the blood vessels in great detail, and you can see here that this is blocked off by the clot. And then, as I mentioned before, we have these small devices now that can go up and snare the clot and pull it out. It's a highly technically skilled procedure, but done with good skill and care, you get an amazing outcome. So the way in which we organise our stroke teams now is around good coordination and communication between the ambulance and the community and arrival in hospital, within the hospital. And we have a lot of time performance indicators, metrics that we try to adhere to, a bit like in Formula One racing, to work well. Ambulance officers are well trained to assess stroke and triage patients in the community. Rapid assessment in the emergency department, and rapid transfer for brain imaging, making decisions about treatment, which in general now is with the thrombolysis drug TPA or alteplase, but there's other thrombolytic drugs which are emerging, which have a similar or even better effect. Some people with an identified clot in one of the blood vessels will go on to endovascular treatment, clot retrieval, and then we have ability to give intensive care therapy for those who are very sick and slow to recover from their stroke. So now acute stroke, instead of being just a hospital-based service, becomes more comprehensive and regional. And through that, we have telemedicine, communications, links between hospital, transferred to more comprehensive stroke centres where there's ability to do 24/7 highly technical clot retrieval and also neurosurgical input. I mentioned before about the emergence of technology now where we can map out blood flow, and we can also use particular colour flow maps to identify the areas of the brain which are dying off or at risk of dying off. So how did we get all this information? How did we make sense of it? We have a hierarchy of research which is very important to guide us. It's a pyramid of research quality. We're at the bottom. We get ideas from laboratory studies. We study new therapies and techniques in animals to show a proof of concept. We have ability to identify particular series of patients and how they've responded. There are what we call observational studies, either case control or cohort, and I'll talk more about this, to look at the association between very particular variables and outcomes. But top of the pyramid is randomized controlled trials that rigorously evaluate therapies with precision and with minimal error. And through all of this information, but predominantly randomized controlled trials, we come up with recommendations that can help doctors and other health professionals in terms of using therapy, giving it appropriately and in safe hands. So when it comes to deciding about particular healthcare interventions, we need research to guide us on how strong is the evidence. Is it level 2 observational studies, or is it level 3 where we've got this high quality randomized controlled trials? Is it one study or multiple studies? How does a particular intervention stack up against other treatments that may have been around for several decades or even new? What would be the size of the benefit of that particular intervention? And as a general rule, surgical treatments where you can remove a problem from the body tend to have a large treatment, whereas medicines, apart from antibiotics or some special immunological therapies, tend to be weaker. So you have to take the therapy for a longer time to realise that benefit in the body. What are the risks involved in terms of, for example, any bleeding risks or any other sort of short-term side effects like nausea or muscle pain? What are the costs? How much do I have to pay over and above what the government may be subsidising the medication? What are the implications in terms of how I should be taking the treatment once a day or multiple times of the day, morning or night? And do I need any monitoring of my blood? And how are you feeling about the medication when you've heard about all of the aspects of the treatment and your condition and the advice or comments that have been given by others? And how quickly do I need to make this decision? It's a complex process of working through these aspects of healthcare decision, and particularly in something like stroke, where you've often got to make these decisions very, very quickly in a very emotive environment where patients are very sick. And we need research, clear evidence to guide us. The importance of research is really to be clear on the question as a researcher, answer it reliably, and then publish it very carefully and well to communicate the results to the community. Unfortunately, most of the research that goes on is not such high quality, and this was highlighted by two famous professors, Professor Doug Altman. He was a professor of medical statistics at Oxford. He said, to maximise the benefit to society, you need not just do the research, you've got to do it well. And so here, Ian Chalmers, who was one of the foundation members of the Cochrane collaboration, he organised a series of articles several years ago in The Lancet where he highlighted this problem of human waste in research. And I guess he's highlighting again that we should do the research very well, but in all things in life, sometimes we don't get it exactly right. Let me explain. Look at this lovely garden. It's well organised. It has a degree of passion associated with it and a commitment. It's organised, so there's some framework in which somebody has put it together. They have done this through various hardships, changes in the weather, maybe some storms, and it's probably not a single person, it's a team. And a lot of pride has got into it and a lot of attention. And research is a bit like this. To put something like this together, you need to work hard on it. You need to be like a builder, have a plan and have a team around you to do it. And if it's a big project, you'll need more people and a larger plan. You may even have to have an army of people around, and if it's international in different countries, you're not fighting, but you are trying to organise things and have your research resilient to any problems that may occur. To do research, you have to impress. Someone has to give you the money, and you need to work with other people, so you have to market and sell your trial to work with other people. And then at the end, you need to communicate the results that is simple and easy to follow. So putting all this together and doing research often requires a business-like strategy to it. Pardon me, let me explain this issue of two types of research. Most research is around association. If we look at a particular risk factor or even a particular drug or strategy, and we want to know about its link to a particular health state or disease state, for example, heart attack, if we want to know whether there is a clear association between these two factors, we need to measure the exposure very well. We need to measure the endpoint particularly well, but we also need to measure a lot of other factors that we know are linked to the risk factor and to the outcome. And by definition, those factors are what we call confounders. So we know that for heart attack and a risk factor like, say, hypertension, that is related to gender or sex, age, smoking, genetic factors, height and weight, diabetes, exercise. All of these variables need to be measured and they need to be taken into account in our analyses to determine whether this factor has independent significance to the outcome. But we can never measure everything, we just don't have enough time. There are things that are left behind, unmeasured confounders, or there are things that we don't know are linked to heart attacks. So at the end of the day, these observational studies that are done are never completely reliable because we can never get rid of all of the factors that may be influencing the outcome of interest. And that's why randomized controls are better in terms of evaluating therapies. We would select and invite particular patients with some characteristics to go into a study. They have to fulfill clear inclusion-exclusion criteria, and we will do a process of randomization, like the toss of a coin. It's generally done now by a computer, where we allocate at random the person to receive a particular intervention. It may be a new drug or therapy or type of healthcare delivery, and the other group of patients to have a comparison. It may be a placebo pill, no active treatment. It may be no treatment. It may be an alternative treatment, your usual care. And we follow up all the patients using the same measures to record a particular outcome. So the beauty of a randomized controlled trial is all of those various variables, confounders that I mentioned before, are balanced between the two groups, and the only thing that we can measure very well is the effect of this intervention over that intervention. Now, there are many challenges, obviously, to randomized controlled trial. You have to get informed consent and explain that to patients. In acute stroke, this is often a great challenge to us because we need to make decisions very quickly in the emergency department. We have to make it as simple as possible for people to read, but also provide as much information about the treatment and why we're giving the treatment, what are the potential benefits and what are the potential harms. And it's always a great challenge for us in balancing off giving enough information, but at the same time making it simple enough for people to understand and approve in an emergency situation. It also means you need to understand why we are using randomization. It's to compare a particular treatment against another. And it's because we're not certain one way or the other. And I know when you go to the doctor, you want the doctor to be definite in his decision making. But often the doctor doesn't know, and he's requesting your acceptance of not knowing, and that we're using randomization to test what particular treatment might be better in future. It also means that you potentially cannot receive a direct benefit from the therapy, but we do know that going into research does provide overall benefits to people. There may be potentially harm, and we have to get indemnity insurance to cover you and patient and doctors who are participating in the research. There's a lot of paperwork and administration and regulatory approvals. Doctors have to do research within limited time, and they need a lot of skill and commitment to be able to do it. And there's a lot of ethics committee and regulatory approvals and access to data and everything that are increasing now, with our society being very aware of confidentiality and protection of privacy. So because of the complexities to randomized controlled trials and bringing new treatments to patient care, it takes a lot of time and a lot of money. So this is the pipeline for the development of a new drug. You discover particular therapies in the laboratory. You discover a treatment that may be therapeutic, and then you have to bring it through clinical trials, which have certain phases, these randomized controlled trials. Phase 1 is generally where we find an optimal dose that provides a potential therapy and no risks. Phase 2 is where we determine that there may be a potential benefit by testing some particular markers in the body, like blood pressure or blood flow or some changes in the chemistry of the blood. And then phase 3 is generally done on a large scale with several thousand patients, where we test that particular treatment to show that it can improve what we call a hard or important clinical endpoint, like survival or freedom from a heart attack or a stroke, or improve physical function. And then if this is a new treatment that's been very successful and shown to work, then you would go to the regulatory agent for a license. And you can see here that the phases here, you're always losing compounds. And to get one new FDA, US FDA regulatory approved drug, you've actually started with several thousand drugs. And so it's only 1 in 10 of drugs that make it through clinical practice, through this clinical phase, actually get approved. And of those, 1 in 10, it's only 1 or 2 that would become what we call a blockbuster, which is a return to the company that's going to pay for all of this business development for all of the other drugs. So you can see the complexity, the long time, and the amount of money going into it. Most randomized controlled trials are done by industry, but they are still done by academic and research groups, because we need to know about treatments and the organisation of therapies that are for public good, not just for business return. And we also need to consider that expensive new treatments are not relevant to all parts of the world. This is a map of where intracerebral hemorrhage rates are around the world. And you can see here that in Australia and Canada and US, Europe, the rates are fairly low, but huge rates in particularly Asia and China, and a huge burden of disease. And we have to find treatments in these very large high-risk populations that are going to be feasible and applicable and accessible to patients, people there who don't have the same level of resources that we have in wealthy countries. So research is very important for training doctors and other healthcare professionals. Always think that you've got to have a clear thinking. You've got to organise the question, organise the design, and write it up. It's very good for your training. It's very good for career prospects and now researchers internationally, and allows you to connect and communicate all across the world. Doing research also gives you a personal satisfaction that you're achieving something, you have a goal, and it's good news. The community likes to hear about new developments. We hear about it every day. every week of new developments that are happening in medical research. In stroke, it's about every month we're coming up with new ideas and new techniques. And working research now is about working in teams and involving you from the community to guide us as to what's important. And that's very enjoyable, because in healthcare now we need to work in teams, and in research we need to work in teams. So doing research is very good for building your organisation with lots of smart people, and that then translates into improved healthcare systems and ultimately improved patient care, which has been absolutely dramatic in my career through the evolution of stroke therapies. I hope that that overview of the background to randomized controlled trials and research, how this has been so important for us to develop new treatments for acute stroke. I wish you well for the rest of your training session, and I hope that Dr. Butcher can follow on from my talk in clarifying any issues that you may have in the audience. Thank you and goodbye.
Well, that was great, wasn't it? It's lovely to understand why it's so important for, I guess, our medical professionals to always be requesting us to go on trials. When I first started with the association several years ago, more years than I care to remember really, then President John Rich was very, very, I guess, directive about the association's involvement in research. He saw that as an absolute paramount development of part of the organisation, because his role and our role, as he saw it, was to make life better, to inform health professionals so that they could build a better system. And, you know, it's really been wonderful to see how his vision of that has played out. We often get invited to participate in research and ask you, our members, to participate in research. And we always make sure that it does follow the guidelines required by the NHMRC and all of the clinical tests that it needs to go through prior to it coming out to ask you to participate. I'm now going to request if Professor Butcher wouldn't mind coming up to the podium and answering a few questions. And so we do have time for a few questions, and Lani will be monitoring the questions online. So if anybody of our online community would like to ask a question, could you just type it in the chat box at the bottom of your screen, and that will then come immediately into the room and Professor Butcher will be able to address it, I'm hoping. Welcome, Ken.
Thank you.
Thank you. So do we have a question from the audience? Any questions at all from the audience about? Okay. I'm actually going to ask one, if that's all right with you, Ken. I would like to know, I think Craig gave us a very good understanding of why we do research. I'd really like you to talk a little bit, if you didn't mind, about how that level of research that he was talking about, that level 1, level 2, level 3 research, is then implemented in the stroke units and the rehab units that we are all working with.
Did you want me to?
Yes, please.
I confess I was having trouble with all the one-ways and the construction, so I missed the beginning of Craig's talk. But I'm guessing, was he talking about phase 1, phase 2, phase 3 research? Oh, yeah, no, that's okay. I mean, ultimately, phase 3 research is what makes it into clinical practice, right? So the stuff I will talk about later is stuff that was proven to be effective in phase 3 research. And I imagine he explained to you there's a diminishing number of trials, right? We start out with a whole bunch of phase 1 and we get into smaller and smaller proven ideas until you get to phase 3. And then there's something called phase 4 research. I don't know if he talked to you about that too, but that's basically where you see how things go in real life. Because there's those phase 3 trials where everything's under pretty perfect conditions. And Craig will often tell you, the best thing that you can hope for as a patient is to be involved in a trial at phase 3 level, but be in the control group, because you have everything looked after so attentively. In addition to your usual standard of care, everyone's watching everything, so nothing gets by. But then phase 4 is, now we're back to real life and how do things work. And we do lots of that in stroke research as well. That's always interesting to see how things play out, and we're actually starting to see some of that with the clot retrieval trials now. Things are more complicated in the real world than they are in the trials, where we're looking at everybody, not selected patients. Does that answer your question? Or is that...
I'd also like you to talk a little bit about the stroke guidelines and the rehab guidelines and how they're used in terms of, I guess, informing clinicians about the best practice to use when they're working with stroke patients. Okay?
Well, the guidelines are always based on the current research. So ideally, the phase 3 trials. The problem you have when you sit on guideline committees and you write guideline statements, which I have throughout my career, both in Canada and here, is that there are many areas that we have to deal with on a day-to-day basis as clinicians where we don't have that phase 3 data. We don't have those trials that Craig talked about. We do those trials to address the questions that get answered, as Craig was alluding to, are based on many different factors. And it's not always because it's a common clinical problem. It should be. But it isn't always. There are other factors that come into play. It's what interests people, what might make money for a company that makes devices or drugs, et cetera. And there are many questions that we have to deal with on a day-to-day basis where we don't have that data, and what we refer to as equipoise, meaning we're not entirely sure where to go, persists. And then guidelines in those situations come down to opinion and interpretation on the available evidence and practice patterns. And then clinicians can interpret and follow those guidelines as they will, which is why we still see considerable variability in practice patterns. Ideally, we will get to a point hopefully over the next 10, 20, 30 years where guidelines are based on more and more solid evidence, and they are adhered to more and more, so that we get a more uniform level of care.
Do we have any? We do?
Oh,
sorry, Lani has a question online. I'll go to the question online first.
So, do you follow the living stroke guidelines that are updated by the Stroke Foundation?
Well, again, as I just said, I guess the short answer to that is yes, right? The living guidelines are a reflection of the best practice and best evidence we have available to us. That would be the short answer. Are they universally applicable? No. There are things there written by a group of people with a view about what to do. So, for instance, the living guidelines recommend using a different clot buster than we currently use in New South Wales. That's not actually approved. It's a little bit out of step with the rest of the world. So I personally, and we in New South Wales, don't use that part of the guideline for practical reasons.
I've had six seizures in, what do you call it? Last one was 5 weeks ago.
Yeah.
And they start coming or going, stop, and they cut off my licence. They stopped my licence.
Yes.
I don't know. Aphasia.
Yeah.
Yeah. Stop.
I'm not sure what the question is.
So I understand you've had a stroke,
Yeah.
you've got aphasia,
Yeah.
I can hear that, and then you've suffered post-stroke seizures.
Yeah.
I think you said you've had 6, but anyway, you've had seizures.
Yeah.
And the last one was recently, and they've taken away your driver's license.
Right, yeah, right.
And the question is, how do we,
Well,
or what causes it? Yeah. So unfortunately, most people, I think the audience probably knows that, don't develop seizures after stroke. But about 1 in 100 people will, about 1% of patients will. And it's because, yeah, okay, so maybe it's a little higher in this room. Yeah. It's because the stroke essentially is a scar, right, on the brain. So it's damaged the wiring. Think of your, it's very simplistic, but I think of the brain, I describe the brain as, computer chips connected by wires, right? And stroke will disrupt that wiring. So now sometimes you get aberrant or abnormal signals. And that's all seizure is. It's just an electrical storm, usually started by the stroke. Most patients, though, most seizures after stroke can be controlled with medication that you have to take. And if you're seizure-free for a period of time that's determined actually by Roads and Maritimes, not by us, you can get your driver's license back. Yeah.
Keep on putting up your medication, doctor.
It does. It's one of those individual things, that's right, where you have to work with your either your neurologist or your seizure specialist, whoever's looking after you. And yeah, it's an individual titration thing. Unfortunately, it's not one of those, here, take this, goodbye things. It's an ongoing process, yeah.
We have another question online.
What do you see the most important research area for stroke going forward?
Oh, wow. Yeah, mine. I actually, probably not mine. I think I've spent a lot of my research career on what a lot of people might consider fairly mundane issues because they're day-to-day issues. So for instance, for me, one of the big things that we have to deal with every day is if you've had a stroke related to a blood clot forming in the heart from an irregular heartbeat. I think most of this audience, I think you're pretty sophisticated, know about atrial fibrillation and the cause of stroke. And the way you prevent the next stroke is by using something we call an anticoagulant. And we have to decide, when are we going to start that anticoagulant? Because we know if we start it too early, we actually can cause bleeding into the fresh stroke. But if we wait too long, some people have another stroke, and that's an awful feeling to have a patient that you're caring for that's in the recovery phase, early recovery phase after stroke, to have another one right in front of you. And we're balancing that. And that's, something that, unfortunately, it's a difficult question to answer. It takes a huge coordinated effort and a lot of randomization, and it's really, really tough. That's just one example. It's sort of, Craig might have talked about hemorrhagic stroke. That's a completely understudied area of stroke. Craig has spent a lot of his career on it and shown some benefits. I think we're still really lagging behind there. It's only 1 in 10 strokes, but we really don't have good treatments there, and there's lots to be done. I could probably keep on going, and I don't know if I could pick one. It's sort of like being asked which of your children is your favorite. It's tough.
We have a question from David.
What is the point of developing guidelines for research if the clinicians are not going to follow the guidelines because they don't agree with it? And because they fail to follow the guidelines, people are suffering, people are being sent home from hospital, not being, no MRIs. What is the whole point of research? Spending millions and millions of dollars if the clinicians are just going to go the whole way, and it's still happening today.
I actually agree with you, and notwithstanding my other comments about guidelines and my own interpretation, like I said, in general, follow the guidelines. And I agree with you that clinicians often are not aware of guidelines, don't keep up with them, have their regular practice patterns. Part of it is the people interested in stroke, like me and Craig, we'd be very familiar with them, right? We're involved with them because that's all we do. All I do is look after stroke, nothing else. I don't even do general neurology. But that isn't the case throughout Australia, right? Or even in New South Wales. There are just a couple of handfuls of people who actually do that. Most people are doing other things. They're busy, they've got other things going on. Is it a question of priorities? Is it a question of hubris, right? Is it a question of I'm the doctor, I know, I'll do right? There's lots of different factors. And you're absolutely right. Translation of our research results and our guidelines into practice is an ongoing battle.
I'm not talking about GPs, I'm talking about specialised stroke teams ignoring the guidelines. Now, those are the guys at the front line. They see it every day. They continually say somebody presents with high catastrophic blood pressure, and they'll say they're not having a stroke. They're not sent for an MRI. They've got no idea what's going on. They just say he's not having a stroke. Now, I've been finding this for 10 years, and it's not changing. I'm still seeing it today. The same thing is going on, and people are dying because of it.
Yeah, I do know what you're talking about. And even in my own hospital, I can tell you that guidelines are not followed. But again, in my hospital, Prince of Wales Hospital, well-established neurological center of excellence, has only one subspecialist trained physician in stroke, and you're looking at him right here. And I battle my colleagues with something that you're talking about on a fairly regular basis, to the point that sometimes I feel fairly shrill, and it is sometimes a thankless task, but we persevere.
Just got one more. We'll take one more from online and we'll take one more from the room. So I'll go with you, Lani, first, please, love.
How do we see these trials demystified for the day-to-day clinical practices and to be able to be incorporated into clinical practice better?
If they seem mystified, that's probably, that could be a problem right there. I always have taken the view that the best clinical trials have a fairly simple design and a fairly simple question that you're addressing. And the results should be clear at the beginning. When a phase 3 trial is designed, at the very start, there should be, what is the expected outcome? What are we hoping to change in clinical practice here as a result of this trial? And I think when it comes to most of the large phase 3 trials that actually has happened, I think the challenge for people like me, who I'm often doing smaller stuff. I'm doing phase 2 stuff, even phase 2A stuff. And I know I'm not going to change practice, right? But I'm trying to generate data that will lead to those phase 3 trials. So that might seem a little more arcane and a little more mystifying. I have to admit, some of the stuff that I have done, but that's in an effort to build the platform to get to those simpler questions.
One more.
Hi, my name's Julie. It's just a fairly brief sort of question. What percentage of the research is done on observation?
I don't know if I could give you a number, but there is a great deal of observational research that is done. I personally, you're talking to some, this is actually has become sort of my first love in research. When I first started doing my area of research, blood flow research, I would spend much of my time begging other clinicians, colleagues, to try to help me collect the data. Could you please just order this blood flow scan? And then I would have to go argue with the radiologist. Could you please do this scan for me? Yeah, it might not change the patient's management, but I won't know till we do it. And also, I'm collecting this data because I'm interested in this disease and I want to test some hypotheses and I need some data to do that. And that's all observational data. You don't get to those phase 3 trials without that observational data, and people like me putting it together and sort of saying, yeah, this is observational, but look what we've seen here, right? And should we address this with a larger trial? So it's critical, but what's happened now, we've actually got to the point that we have so much data coming in, and it's gotten much better, right? I mean, it used to be everything was written down in paper, and it was written down haphazardly, and it was a real nightmare to get it. And observational research would often mean going down to the clinical records room and burying yourself in charts, flipping through this stuff for hours and hours. We now have electronic medical records, and now we have the imaging data all electronic. It's no longer, I'm old enough that I used to hold up images like this, right, on an acetate and put them up on paper. Actually, don't hold them up like that. One of my teachers said, this is a little joke for you, do you know what you call the neurologist who looks at his CT scans like that? Hold them up to the light. He said, the defendant. Not a good idea. He used to put them up on the light box. But now we've got all this data. And I'm of the view that all of these data should automatically be used for research. It should be an opt-out procedure. Obviously, we have to protect people's privacy. Obviously, we have to go through the ethics approvals, which sometimes can be onerous and difficult. But I am of the view that if you have been cared for in a public hospital, unless you tell me, I don't want my anonymized data to be used, it should all be going into research platforms. And we have so much potential now with these big data electronic platforms. Most people probably don't realize this, but all of your images, when you have your CAT scans and MRIs now in public hospitals, they're all being stored on the cloud, right? It's all something that's being provided for by Amazon Web Services. And they do incredible things with recognition, automatic recognition. If Google can recognize your face, right, and they can tell you, I can tell you're not a human being because you don't know what a motorcycle is or what a stop sign is, we should be able to have these algorithms say, that's a stroke. And by the way, the doctor who's not following the guidelines, who's not recognizing the stroke, I'm going to send you a message on your phone to wake up, right? That, to me, is the future. And that all starts with observational research. That's too long an answer to a short question, but... Yeah, you're welcome.
Thank you. We're going to break for morning tea now, but before we do that, I would like to acknowledge the fact that Ken has come out and basically stood on the podium and answered questions from you all, and also for those of you online. It's been a pleasure having him do that. He will be our next keynote speaker after morning tea. I'd also like to, while he is not with us, also acknowledge the presentation done by Craig Anderson. It was excellent. It does give us an idea of the importance of research, the fact that it's not a short-term thing, that it takes a long time to get the observational information and the detailed information for clinicians to be able to change their practice. And it really is like, it's a very big organisation, health, and getting research into practice is a long and involved process. And as we go through the day today, we'll be addressing some of the ways that this has occurred over the last 45 years. And I look forward to the other presentations. However, I would like to thank Craig, and I would particularly like to thank Professor Butcher for his really standing up and taking the questions without any notice really at all. So thanks very much, Ken.